Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, I'd like to introduce to you my friend, Lisa Bachan. She started scanning in 1985. At that time, it was mostly on-the-job training with only a handful of schools in the U.S. that were open. Very few were accredited. She chose NYU School of Ultrasound and graduated with honors and was the president of the class. Her love for research started there. She won the top 2 clinical rotations at NYU and Mount Sinai. There were other rotations, but those 2 were the ones that she was the most proud of. She was a staff sonographer for several years, and then she started teaching physics and OB-GYN at Woonsocket Hospital. That is now a formal accredited program at Community College of Rhode Island. She was involved with research at Yale, then went on to become the program director there. She moved to South Carolina to care for her stepfather and worked at MUSC as a staff sonographer and worked her way up to a clinical instructor. She was also teaching physics at Trident Technical College. She left that to be CEO of Charleston Ultrasound Institute. CUI housed a clinic, a school of echo and vascular and research. After a few more jobs in various settings, she started as an applications specialist at Ultra Select Medical. At the time, she was only one of two apps ladies in South Carolina. Now she owns and operates Lisa Bachan Speaks, which involves public speaking, applications, classes, and research. She wants our listeners to know that she never stopped scanning a full load of daily patients until she went to USM. Please help me welcome Lisa Bachan. Please help me welcome Lisa Bachan. Lisa, thank you for coming on our podcast again. I think for our second visit with you. And this time, our topic with you is research. And I'm excited about this topic because this is an area in which I wish I knew more about and could be a part of more often, because I think doing research really gives you a voice. It gives you a platform of knowing your specialty even more, right?
Absolutely.
And kind of being an authority on a certain topic. And so I think it's important for us as ultrasound techs. I know in my education, never covered, right? Never. What I've learned is what I've kind of picked up and got from here, there, and everywhere, and doing my own little bit of research, but it's not part of our curriculum.
No.
And so
now you have a bachelor's degree from a really good 4-year institution. They usually have something that touches on it. It may not be the scope that is necessary, but they at least touch on it. You have the basics, basic statistics and those kinds of things.
Right. I agree. But how is the field of research, how is that different than scanning daily patients on a routine basis? What does that life look like in research?
Much nicer. If you have a really well-funded study, well budgeted and things like that, generally it's not what you and I call churn and burn. Every 15 minutes you've got to turn out a paper. It might be, a bilateral arterial, but by God, you better get that done in 15 minutes in the clinical.
Right.
But in research, you have to understand that you're probably part of a much larger equation and that you cannot afford to tank a $6 million study. So you have so precise in your imaging, in your measurements, in following the protocol to an absolute T. It's also helpful to know how to consent patients. If you have venipuncture experience, that will help you pave the way. Any blood lab experience, any taking vital signs. Again, that's where my nursing background came in very handy. In Charleston, South Carolina, we used to have a very powerful CRO, and that stands for Contract Research Organization. And I contracted them. I started out through another echocardiographic doctor's office, but that didn't last very long. So I would go and scan the patients there at the other office and then go to work at my cardiac scanning job. But what I like about research is you're generally speaking, I mean, there's exceptions to everything, but generally speaking, you're given a lot longer to scan the patient and obtain the data per the protocol so that you can have that really good data for the statisticians and the doctors to work on. Now, there's some instances where the physicians will be very open to you participating in things like literature review. Maybe they'll have you write a section of an article and you can get your name on that article.
Right.
When I started out, I was a little naive in that. Now I always say I send them a contract, and if I'm going to do your research, and if I'm going to, depending on how the research is structured, I will say I want my name on that paper.
Right.
I've heard it.
Or, we are the ETAL.
Yes,
right?
that's right. At the very tail end.
Right?
Yeah.
He did all the numbers and the crunching, the doctor did, but where's our name on that report? Well, you are the ETAL.
That's right. That's right. But I think early on, when I was a student and my clinical rotation was at Mount Sinai, and I was so lucky to have the medical director who was so involved in everything. He just didn't sit behind his desk and sign papers all day long. He would be deeply involved in everything, but he loved research. And that just got my interest up, and I was just so excited to learn new things and tweaking machines. And so the very first study that I did at Mount Sinai, I did temperature map, which we now call, either depending on your manufacturer, chroma map. Some do call them tint map. But the original reason that research was done, because the thought process was that different diseases like cancer had a different temperature than surrounding normal tissue. Well, it became quite clear early on that the hypothesis was not working. However, what it did do is it helped your boundary detection, your eye detection, and it protected sonographers' eye. Because remember, at that time, we were not allowed backlit keyboards. That didn't exist back then. And we existed in complete darkness.
Right.
So what happens when you're in the dark for 8, 9, 10, 12 hours a day, 5 days a week, 6 days a week? You lose your eyesight. So your lenses do not open and close properly. The very first lady who ever trained me in ultrasound, Sharon Kagan, actually went blind before she died. Completely blind. No color, no light differentiation, nothing. And I kept thinking, boy, there has got to be some advances in this. And I noticed a lot of other sonographers would retire. Now, we didn't know much about macular degeneration then, but that was a big problem now that we know what it is. So there was that whole temperature map research that we did. And now it's on every single manufacturer. Now, granted, there were two research projects going on at the same time in different parts of the country, but we were well funded. And again, taking much longer to scan each patient, making sure that every little detail was absolutely correct. Then I had to leave that rotation because my time was up. So I went to study with Dr. Raghavendra, who was the medical director at NYU. And he was doing a research project on liver metastasis. So I got really, really good at really pinpointing mass margins and using different techniques. Now, we didn't call it dynamic range necessarily back then. We would call it, amplitude or some other
Right.
dated term, but it's called dynamic range now, or dynamic contrast, and how to change it to bring those borders out. And he would tell the radiology residents, the sonographer would scan, but then he'd like, no, Lisa has to get in there, and then the resident has to get in there. And sometimes the resident and I were together. But that was such a valuable thing in the data, just to see how that data transpired and what it manifested in later on, and how it would help save lives.
Yeah.
Characterize tumors, how close were tumors to each other in the liver. It was really fascinating. And that just furthered my interest in it. And fast forward many years, well, Dr. Raghavendra now, one town over from me, and we're always trying to dream up research projects.
Fun.
Get their hands on it. So, once
So
a
was
week.
that your favorite thing to study then?
liver.
The liver and mets and borders?
No, it was what, as a student, you do what you're told.
Right,
So
right.
I couldn't say, oh, well, I don't like the liver, I want to do something.
Right.
Golden opportunity, and I grabbed that opportunity, and I was like, oh,
Yeah.
I'm gonna learn everything I can.
Right.
Thing about research is you have to understand data, you have to understand statistics. There's a whole lot of other training that goes into it. Most of the time we have to do it on our own. And when our CRO said, okay, well, we're going to use you more for different types of research, and we know that you love it and you're really good at it. You're really good at, doing like protocol development, because they'd send these big manuals. And it was, first of all, the measurements that you put in the manuals aren't even designed to measure what you want to measure. So let's rewrite them. I'll write it. How's that? And you pay
Yeah.
me. So that happened more than once. So through that CRO, he said, okay, well, the time has come when you're going to need some other credential. You're going to have to do some extra study beyond the 4 years that you have in your time in ultrasound education. So I'm like, well, what is it? How do I do it? How do I fix this? So they paid for everything. They got me into the city program, and it was 2 hours a day every Friday for 13 weeks. And you are required to get a 94th percentile or above. So there's a lot of reading, rereading, taking of notes, and making sure that you've got it right for all of the tests that you have to take. And that's
Right.
just a small section of
Right.
research. There's probably 23 others that I can think of right off the top of my head. But, if you really want to pursue it, I would really strongly suggest getting in with a CRO who will help you with that. Or you could go to gain employment as a research sonographer at some place like Boston Scientific, Ellipsis Corporation, Medtronic, some of these big corporations that will do research, and they can self-fund.
Right.
Now, those kinds of things, you just get paid your salary. But somebody like me who worked for a CRO, I generally got paid by the patient.
Mhm.
You have to be wary, because you're going to owe taxes. When the tax man comes, you're going
Right.
to owe. So you
Right.
budget very carefully. Sometimes you can do it by a contract, but there again, typically contract, or what the IRS calls 1099, you still have to budget and you will still owe.
Well, and some studies have just X amount of dollars. So when X amount of dollars is out, then X amount of dollars is out. So like you said, budgeting those dollars is really important, right? and knowing what you're going to need those for.
Right.
And I know there's a bunch of different software too that helps you to plug your numbers in and run your numbers and do some of that statistical work for you.
Right, right. But fortunately, sonographers really aren't doing the statistics. They're probably generating images in a certain way or using a certain technology. They're generating numbers that will be given. But generally speaking, I think every project I was involved in had their own statistician, and that's their job. They sit there and crunch the numbers and come up with the standard deviations, means, modes, all of that stuff.
Right.
T-squares, positive predictive value. They set the a priori at whatever number they know is appropriate. So
Right.
we generally don't have to do that, which is kind of nice because I think you have to be a really special kind of person to do
To like that, right.
six all day long.
Well, and understands sensitivity versus specificity and those kind of things as well, right? I mean, there's differences between the two and what makes a test good versus, not as accurate and different things like that. Plus the different kinds of studies, right? There's a retrospective study or a prospective study or like you said, a literature review. So there's a lot of different kinds of ways that you can study things. As well. So it's not just so cut and dry. It's like a whole new different field in and of itself, right? And so I think that's what's kind of fascinating to me is getting into that or using part of it. I think as sonographers, I think we can be a lot more active in wanting to do that. For instance, one of the areas I think that really needs to be studied is diabetes. Like
Oh,
in pregnancy, like it hasn't been studied since the 70s,
mhm.
like we really need to get new numbers or
Right.
something, get new information that would really help us understand that field so much better,
Definitely.
but
Absolutely. That and hypertension, anything to do with
right.
hypertension really needs to be really well studied.
Yeah.
Yeah.
Yeah. So what was one of your favorite things to study when you did research?
I'd probably say the Timmy Engage drug study. I don't know what the trade name of the article turned out to be because I left that particular clinic before the study was finished, but it was a study that looked at a new atrial fibrillation drug.
Right.
So had wash in, wash out, and we followed these patients over a period of time to see how that drug worked, and that was pretty exciting.
Okay. And what was the least favorite thing that you've done research and studies on?
I'd probably say the tint map one
Ah,
because it
okay.
proved the hypothesis.
Yeah.
It just opened up another avenue to help sonographers, which I love that. But I think that was probably my least favorite one.
When it was a little bit more disappointing. At
Yeah.
least on some of the others, you feel like it really contributed to the health of people, right? I
Yeah.
think in research, you feel like, wow, that we found this out, and this is a real contribution to our education in this field, right?
Yes.
But when it doesn't go your way, or when it doesn't go the way you think it's going to go, right?
Mm-hmm.
It could be a little harder to stick to it, I think, sometimes.
Yes. And you're always
The
worried about,
research will really show.
you're always thinking about where is that money going to come from? And, not just for yourself, but for the rest of the staff that's involved. And you're always, like we did the gallbladder study with Dr. K, who's from England, and gallbladder treatment, I mean, and we lost funding partway through and we never knew why. It's not like we weren't doing what we were supposed to do. It's not like the data was not good or the images weren't good or that we, absconded with all his money. That was never the case. They just stopped, and that does happen.
Oh, wow. Yeah. I didn't even think about that avenue of it, where they're probably funding it themselves and maybe found something else a little bit more passionate to spend their money on. And because maybe they weren't getting the results they thought they would
That
get.
could very well be. Yeah.
Who knows?
Mm-hmm.
Knows. So, why do you think ultrasound or research is needed for ultrasound?
Oh gosh, because we could open up so many avenues. Like you said, wound care and diabetes, huge.
Yeah.
You need those arterial numbers. You need to have that correlated with the drug study or during a drug study. So many of these things, causative agents for obesity. I mean, obesity rates have just skyrocketed, and it's not just the over 50 population like you would assume that it would be. It's childhood obesity, teenage obesity, early 20s obesity, and it just worse from there.
Right.
So, things that, answer the why question. Figure out answers to things, more drug studies using ultrasound. The captopril study in kidney function was fascinating, that related directly to hypertension back in the 90s. That was actually a multi-center nascent study that I participated in with Dr. Denise Mulvihill. She was an excellent doctor, now retired, unfortunately. But they just need to be ultrasound friendly in doing their ultrasound because it's much more cost effective. It's portable. But I think some of the reasons that physicians don't cotton to it too well is because it's operator dependent and your data is directly related to the pictures that you're taking. Well, if you have a doctor that can't find the freeze button on the machine, how's he or she going to take the pictures? They're busy treating and doing other things. So then it falls to the sonographer. And, how good is that sonographer? How well has that sonographer been vetted for this research project?
Yeah. And it's hard to do, like, when we talk about diabetes and pregnancy or some huge research that you would have to do from a multi-site study. Right?
Correct.
Get every site on board with the same way to do things doing research is a huge project. It's training people. It's knowing exactly what you need and what you want and how to get the numbers. And I think I was a part of a study with a pediatric cardiologist on tachycardia, different types of tachycardia, drugs used and whatever. And they needed to get blood drawn and send it to this one person and, check their baby's heart rate 3 times a day and record it's a lot of information that you're hoping that people are doing right.
Correct. And also today with EMR, like, back in, years ago, we didn't have EMR. It became legally mandated through the Obama administration.
That's right.
But we didn't have it. We had paper notes.
I know that you could hardly read.
That's right.
I still use some of those abbreviations like with and every and when I'm writing different things. But no more, right? No more.
No, we have to. That's right. Everything.
You can tell who the doctor was by the handwriting,
That's right.
or the lack thereof of the writing. So what do you need to know in order to be able to go into, because I've known several people who have gone from ultrasound into research, but or I'm sorry, I know nurses go from nursing into research. And so if they can do it, why can't we do it? We should be able to do that.
And, opening up now, I think because nurses, unless they are, ARDMS or CCI licensed or ARRT, but generally nurses can't take ARRT. They're limited to either the CCI pathway or the ARDMS. ARDMS still being really the gold standard because it's a much tougher exam. Or at least that's my opinion. I guess I'll qualify it that way, having been an educator for quite some time. But you have to know, patient assessment, vital sign, how to evaluate a patient, blood draws, venipuncture, IV stick, basic pharmacology. So that's one of the things that I had gotten in my basic nursing training. Granted, it was very watered down at the time, but I was lucky enough when I was the CEO of Charleston Ultrasound Institute to have 3 doctors in the same office who were also researchers and really good clinicians. Well, the head doctor said to me, "Lisa, I think you're getting a little bored. I'm going to sign you up to audit pharmacology at the medical school."
Oh my.
like, yeah, just act like you belong there, wear your lab coat, you'll be fine. So I did. I
Oh,
audited it and I thought, oh boy, we need pharmacology for sonography because this is a whole different ball of wax. This just opened my eyes to all sorts of things. So now when I go to talk to high school about the field of ultrasound, I always put the osmolality equation up on the board or the whiteboard or, TV or whatever they're using in their classroom. Like, you remember that algebra you thought you didn't need? Get to it, people.
that's right. That's right.
So,
That's
I
right.
benefit of this kind of varied background that's somewhat unusual for a sonographer, partly because I had doctors, some, not all, that believed in me and the abilities and the ability of a sonographer to make that difference and to make that leap.
Right.
There are a lot of doctors, as I'm sure you well know, that just want to keep you in your space, just push the buttons really fast, get the
Make me money, make me money, make me money.
paper
Right.
burned.
Which I think is really the hard part about doing research, right? Sometimes is they don't want you to be taken away from doing that patient and getting that patient in and them getting paid. And
Right. And that's what makes it extra stressful on a sonographer. And I say, in a big institution, if they're really serious about doing research that uses ultrasound, they need a dedicated research sonographer, who has different types of certification within the research realm. They may even have another certification called certified research assistant or certified research coordinator or something like that. That's what they really should have, and have it not be grant funded salary. Have it just be, part of an operational budget for the department.
right.
That's the way to handle it.
Yeah, but we're small in numbers sometimes,
Right.
So
That's right.
talk to me about salary in research versus patient care. Is it relatively the same or what does that look like?
It is now. Some of the contracts I've had have been very lucrative. Some were done as just part of my regular salary, like the cycloclarity study. That was just done as part of my regular salary because it was in my job description that's what I'm supposed to do. So that was fun. And it was probably better to be done that way. Actually, I think it was more cost savings for everybody.
Right, right.
Past, if you were a dedicated research sonographer, and I've known a few over the years, they started out, in the $95,000 a year because they had extra skills, they had extra education. Most of them had a bachelor's degree back in the day. Now, several of them have a master. So you can see that it's equaling other types of professions like nursing.
Right.
There is a newer designation, advanced radiology professional, which is similar to a nursing practitioner or PA. It's built
Right.
on that model.
Right. And I think as I spoke with Joy Guthrie from SCMS this year, she is piloting several sonographers for advanced practice sonography. And I spoke with her and she's like, we know how to scan. It's just we've never done research. We don't understand the research part. And so a lot of the advanced practice is the research part,
Right.
and
Well, there's a lot we don't know as
right,
sonographers. We have
right,
to have, microbiology must be included. It's a lab science. You're not going to learn it just from a book.
right.
Have to have that lab and somebody who can teach that lab. Things like, pharmacology, there's a lot that anything in the advance, it's not just the research,
Right.
is all of the other ball of wax to make you far more competent clinician.
Right, right. Yeah. And so I think because it's a new advanced practice, and it's different in each modality, right?
Hmm.
And the drugs are different, right? But I
Hmm.
still think the basic understanding of it is still vital, right?
Correct.
And
Yes.
so yeah, I think you're right. I think microbiology and pharmacology, some of those basic things really need to be a part of our education, especially for advanced practice. Needs
Yes.
to be really unified, But I'm excited that the research has kind of caught up. Back in the day, research was known not to pay very well.
Correct.
So I'm encouraged to hear that it's kind of caught up with regular salaries, because it is pretty vital, and my introverted friends would love to know that this is a possible option for them somewhere, right?
Right.
So I'm excited for our field, because I think we are on the verge of just exploring new possibilities and learning more and more new things, right? That we should be able to know about, and be able to do. So I'm excited for this research part of it. Hopefully we'll get more into it and be exposed to it, and we'll encourage each other to do more of it, right?
Right.
As part of our routine, part of our jobs,
Right.
so that we can understand it and move our profession forward. I think
Correct.
our profession problem is we're smaller in numbers compared to nursing, right?
Right.
So our voice isn't as big.
That's right.
Yet we do have a voice, and that's why I feel so passionate here lately about making sure that, I'm in a time in my life now where I'm an empty nester, and I can really focus on my profession, where I couldn't when I was younger because I was raising children, right? And so to move our profession forward by being active in our SDMS and our ARDMS and different things like that, like others have done for us before, right?
That's
And
right.
so I'm excited about this new generation that's coming up, and kind of helping us to stretch our wings a little bit.
Correct.
So, and research will definitely be doing that, stretching our wings and moving us forward. So thank you for sharing your experience and your knowledge about this profession and this possibly new line of options for ultrasound people. I think having options available to us is vital to our existence. And we thank you very much for sharing that. And thank you so much.
Thanks for having me. I appreciate it. You're doing a great thing with this podcast.
Thank you. Thank you for tuning in to It's All About the Frequency podcast. I hope you've enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.